And then moving on to the transient ischemic attack. So a TIA is defined clinically by the temporary nature of the associated neurological symptoms, which last less than 24 hours by the classic definition. The definition is changing with recognition that transient neurological symptoms are frequently associated with permanent brain tissue injury. An episode of brain, spinal cord, or retinal ischemia resulting in focal neurological dysfunction, usually for less than an hour. This is the definition found in our standard treatment guidelines. These patients are at high risk of subsequent stroke the week after a TIA, and the differential diagnosis for a TIA is similar to that of a stroke. The ABCD2 scoring system is used to determine the risk of a stroke happening in these patients who have suffered a TIA. A score more than or equal to 4 is considered high risk and warrants urgent investigation and management, as the risk of stroke within the next week is more than or equal to 4%. So the ABCD2 score looks at the age, the blood pressure, clinical features, duration, and the presence of diabetes. And then from there, the points are gathered up, and then the risk is determined based on the table there at the bottom. In those patients with cardioembolic disease, in patients with cardioembolic disease, warfarin should be started at 5 milligrams and INR checked after 48 hours. Thereafter, the INR needs to be checked every 1 to 2 days while adjusting warfarin until therapeutic range, which is 2 to 3. Other patients need to receive aspirin 150 milligrams daily, simvastatin 40 milligrams nocte, and then if on amlodipine, then simvastatin 10 milligrams. If the patient develops muscle pains, then give simvastatin 10 milligrams, and then if on protease inhibitors, then you give atorvastatin 10 milligrams. And then brain hemorrhage. So there are two main subtypes of brain hemorrhage.